Hello everyone, my name is Kevin Turner. I am a clinical specialist in sexual health and HIV based down at Sexual Health Dorset, but also at the University of the West of England, where I contribute to some work around the SHWIG, which is the Sexual Health and Wellbeing Interest Group. So that's a group of academics that focus primarily on work around sexual health and wellbeing. So today I am going to be talking to you about the outcomes from a piece of research that I did, along with some recommendations for practice, looking at the unmet sexual health needs of male sex workers. So, next slide. Okay, perfect. So when we think about the health and well-being of male sex workers, this is usually largely informed by misconceptions around the sexual labour. And often this can end up driving physical health interventions. So we will all be familiar with the biomedical interventions that we see offered to people within NHS-based sexual health services. These generally tend to be orientated around improved access to condom provision, testing for STIs and HIV, vaccination programs for hepatitis B, hepatitis A, and HPV, in addition to PrEP, so pre-exposure prophylaxis for HIV. But often we hear about how these will miss the psychosocial care needs of men who are selling sex. So what we decided to do was acknowledge that a lot of health programs are offered based upon a focus of perceived need and try and find out a little bit more about how we can improve offers of support for male sex workers around their health and well-being. Now, in order to be able to do this, we recognised that we needed to adopt a really person-led framework to undertaking this research. It was really important that it adopted a benefits-based lens. So we'd already heard about lots of sex workers who had been involved in previous research and had spoken quite openly about their experiences of finding that quite exploitive. So often undergraduate students would come in, do some research, and it would benefit the researcher, not the community it was working with. So it was really important that we were able to formulate and then mobilize some recommendations so that participation was worthwhile. In acknowledgement that previous interventions were based on actual rather than perceived need, we really wanted to engage with lived experience, not only in the participation of some qualitative interviews, but also within the framing and the design of the study. So we formulated together a stakeholder engagement group. This was primarily made up of people with lived experience who were either actively or had had a previous history of engaging in commercial sexual services. It was really important for us to acknowledge positionality within this and recognise the dynamics between the interviewer and the interviewed as well. In recognition that this isn't a homogenous group, it was really important that we had some flexibility within the framework that we'd chosen and our approach to research, just in acknowledgement that men were coming from different backgrounds, were engaging in different jobs within the community. So we made sure that opportunities to participate in the research also could take place over evenings and weekends as well. So from our stakeholder engagement group, like I said before, it was predominantly made up of people with lived experience, but we were also really keen to incorporate sex working academics, sex worker researchers, people from sex worker support organisations, and also people who were delivering care to sex workers within mainstream sort of NHS health services. Within those meetings and within initial interviews, we realised really quickly that men spoke quite a lot about a lack of recognition with traditional sex worker terminology, often used by sexual health and NHS services in attempts to try and reach them. And there was a really call for us to change what we are calling sex work. Here you'll see some quotes. These just have to illustrate the points they're taken from the interviews that we undertook. A lot of men didn't really recognize what they were doing as being sex work. And this really helped to highlight that this was language that was really more so relied upon by healthcare professionals rather than people sort of engaging within commercial sex work. A lot of men also didn't like to use this terminology because they didn't always conceive of it as work or as a job. Now, some men did and used the term sex worker in a very activist kind of way, and that was in response to sort of legal frameworks around decriminalisation. But it's interesting that as public health professionals, we refer to these people as a community or a population at risk by sex working, but often they don't recognise what they're doing as work. One of the instant recommendations that we took on board was that health services can start by using really, really inclusive language. So when we had roundtable discussions, it was very much trying to focus on the fact that people often describe their experience through pre-existing roles, such as escort, porn actor, porn performance. But we started to notice this new nuances through the availability of online subscription websites such as OnlyFans or Just for Fans, where people were franchising on this language as well. You'll notice at the bottom of this slide, there are two emojis of a credit card and of some money. And this is just to highlight that for some people, the language was so complex that they removed away from it and started to use emojis as a way to signal to other people their availability to start accepting rewards. The rise in OnlyFans has had a really big impact on sex work, with lots of people with reduced barriers to signing up. It's made it more accessible for people, and because largely it's driven by social media, I think it's had an impact on some stigma or the way in which sex work is viewed by people. So we decided to adopt this language around accepting rewards. And as psychologists, we really, really liked this because it was looking more at describing the behavior rather than using labels to label people. When we looked at what drove people to engage in sort of reward sex, it mostly focused around this idea of money and pleasure as well. So entry was either accidental or it was survival based. This idea of accidental sex work was new, and it was something that quite a lot of the men spoke about, and it really challenged the stereotypes that we sometimes have as sex workers being powerless or needing help or being rescued. So there was a lot of choice and there was a lot of agency within these discussions. So here we hear from James, who's 28, bisexual. He described his experience as actively receiving money for sex. And the first time that he did it, he was just having regular sex with a guy, and the guy had given him £200. It became a good, lucrative resource for him and encouraged him to carry on sort of seeking other opportunities around this. On the other end of the spectrum, we heard from Luke, who was 35, identified as gay, and he described what he was doing as active sex work. And he engaged in it because he was in a relationship where he had to take care of himself and a partner, and escorting was a really good way to supplement the part-time job, which at the time was all that he could get. Often when we think about sex work, and I know within clinics, we're often encouraged to try and find out what type of sex work people are doing. Within the discussions with men, it became very evident earlier on that men work across a range of multiple platforms, and therefore these monolithic identity labels, don't have much use to us anymore. Luke's experience, he started off escorting and then did porn in order to get some free photos that he could then use to try and advertise opportunities for clients to get in touch with him. He then started to do brothel work because it's one of the very few places where it's possible for condoms to be used. So it brings in this idea as well that different platforms of sex work potentially are higher risk or lower risk in comparison. So already these new findings help to challenge what we already know about sex work, which has previously been classified into either sex work that is direct, so direct involvement with a client, or indirect, where there isn't much sort of body contact. And when we think back to the OnlyFans situations, that would be seen as being low risk because there is no contact with a client, but there still would be an element of risk for the creators who may be having bareback sex between them. On OnlyFans and just for fans, there isn't a need for certification like there would be when you're working with a porn studio as well. So it's a slightly different backdrop to what we're used to. And again, we're not entirely sure what the impact of that is on people's risk, both perceived and recognized. So, in order to understand what people were doing, it was really important for us to focus on their behaviours. We did a thematic analysis across 14 interviews, and something that was really prevalent within that was this idea of tools of the trade. So, things that people relied upon that helped to support them with the work that they were doing. Right at the very forefront was a performance pressure for men to stay hard for longer, which led for many men to experiment with recreational drug use. So Viagra was often relied upon. It helped people to stay harder for longer. People who were misusing Viagra were also using cocaine as well. People liked Viagra because then it took away those performance pressures of having to achieve and sustain an erection as well. And that was experienced as something that was quite normal amongst the community. Having the right look was also really, really important for people. And here, steroid use was framed outside of a substance misuse. A lot of men reported experiencing body image. They were aware of people that were bigger with them, that were seen as being more hyper-masculine. Here we hear about Ricky, who ended up trying steroids, which was very big for him in his industry, where he was working as a stripper. For him, he ended up with a couple of health complications from doing this because he didn't have access to resources that was very much framed by intravenous drug use. So he very much distanced himself away from this. So a lot of men that he was working with weren't using needle exchange services, and found it very difficult accessing them from either needle exchange services within drug and alcohol services, or he mentioned about a needle exchange service within Boots. He said it wasn't very confidential, which led to him potentially continuously using needles even when they were blunt. Right at the very heart of some of the tools of the trade was this idea of being reputable. And I think this really challenges this idea of male sex workers as being potentially very reckless or irresponsible about their health. The study very much was picking up on what people were doing to maintain their health, in addition to try and find out where that unmet need was. Being reputable was really, really important because this helped to determine their success within the industry. Men get paid a lot less than women, and it's really important for them to have a good reputation. Often, one of the things as clinicians, we try and give sex workers as many condoms as we can to try and reduce risk, but bareback sex sells more. So sex workers tend not to use condoms when they're doing porn shoots. Instead, they get certificated usually every 28 to 30 days. So they would go to a sexual health clinic, get tested for everything, give proof of testing to the production staff, and then that would enable them, they're almost zero sorting through their professional partners. Some people really wanted to safeguard this, and would often avoid having sex with people outside of the industry because they weren't certed. So in this scenario, sex workers aren't the high risk. It's actually people who aren't in the industry and aren't accessing sort of regular screening. One of the main issues we heard about is when you get a cert, it's often dated from the date that the specimen was taken. But service level agreements with testing laboratories often mean that these men were having to wait up to 16 to 18 days to get their results back. So when they were eventually getting a cert, they could only really work off of it for about 2 weeks before they would need to present again to have another screen taken. When they did ask for proof of screening, there was a lack of competence, cultural competence from NHS staff who didn't really understand what a letter would be needed for, or to go about what would be written, what would need to be written inside of one. Often, when I talk to NHS clinicians about the health and wellbeing needs of sex workers, a lot of them will say, oh, once they've got PrEP and they've had their vaccinations, they don't really sort of need anything else, which in my opinion is a little bit naive and doesn't address those wider sort of psychosocial issues. When we spoke to the men that we interviewed about that, a lot of the time they didn't associate themselves as being high risk. And this was because of these health seeking behaviours around certificates, safeguarding the validity of these by only having sex with professional partners, and really thinking about sexual behaviours. So for a lot of heterosexual men who weren't engaging in any anal sex, they didn't feel that they would benefit from PrEP at all. Those that were accessing PrEPs from clinics found it really, really difficult, and particularly in having to disclose the sex work if they weren't MSM, so men having sex with men. So this often led to people sharing supplies with others, or concentrating their work to reflect rationing. So here we hear from Chris, who's an active performer. He's heterosexual. He doesn't use PrEP because I wouldn't do high risk things. Simon, who's 23, a trans man, bisexual, active sex worker, said that a lot of men feel too scared to bring it up at the sexual health clinic, which means that a lot of them just don't go and get it. A lot of people don't take it properly, so we know that there are lots of different ways to take PrEP, but often this is because they are sharing it amongst each other. So what they will then do is see a lot of clients in one day rather than sort of spacing it out. One recommendation from Simon was that if sexual health clinics were saying we have PrEP and we have it for sex workers and we're not going to be weird about it, then that might help to encourage engagement with it. But at the minute, people are too freaked out about being open with services. So for a lot of these men, sexual health clinics were an ideal destination to access preventative tools, but also ones which would help to support the work they were engaging in. We heard about the inabilities to access certs and PrEP and about a lack of cultural competency around industry requirements, but a lot of it is fueled by assumptions from clinical staff, which again are much more located in an actual rather than a perceived focus. This led to a lot of men going down to Dean Street in London, where they were able to access same-day testing, and clinical staff were much used to dealing with industry requirements and were able to provide a certificate. When thinking about recommendations, people felt that this healthcare destination would be ideally situated to be able to give out other resources that would be able to help and support health and well-being, which across interviews were multifaceted. So when we talk about sex workers collectively, we think about them as sex working communities. There was a slight irony with this within the interviews that we did, because people felt a lack of sense of community and felt very, very isolated. For this reason, there was an interest in peer support and lived experience, particularly around stealthing, sexual assault, and non-payment. There is a lot of toxic masculinities around men accessing health and support. So it's really thinking about ways in which men can access health information discreetly and anonymously. So there is an interest in digital platforms and digital healthcare. Relationships was a big issue for a lot of people, particularly if they were in a relationship, if it's a straight male working in a relationship with a female, often there would be jealousy. Sometimes these men would put off sex with their romantic partners so that they could fulfill the performance pressures of their work. But also trying to think about navigating relationships and disclosure and acceptance of their accepting rewards work. So there's definitely some movement there for some psychosexual sort of engagement. Also, when we think about erectile dysfunction or the demands that it puts on people doing reward sex. The pressures of physical desire led to people focusing on steroid use, and we know that people aren't accessing risk reduction information that isn't tailored to their context. So developing some resources that are contextualized by this and have stories based on lived experience will give people opportunities to relate in a much more meaningful way. And we also need to think about needle exchange in the ways in which this is made available for people. So as we are rounding up on the slides that I have shown you, there is a frustration in some services that we're seen to be tokenistically advertising for sex workers. So passive approaches of running sex worker clinics don't work. Sex workers won't just show up. There has to be a benefit. Some men spoke about that they would rather not be seen in a designated sex worker clinic because often they might not want to be associated with people who aren't following sort of industry guidelines and requirements. At the very heart of this was that they would advocate for more engagement, and without it, it almost feels like they don't exist or that their needs don't matter. So, in conclusion, if you are thinking about developing sex worker services or you want to improve your current provision, we need to try and focus on an improved cultural competency within healthcare services, predominantly with sexual health, but further and beyond. Any sort of interventions or implementations should be done alongside lived experience in a co-production approach. And this engagement is something that needs to be ongoing. So trust is really, really key here. This will help to ensure that you're delivering care that meets the actual rather than perceived needs, and helps to ensure that services are, discreet and meaningful rather than being tokenistic. So far, when we're thinking about next steps, we have formulated our findings and our recommendations, and these have been fed into the BASH, so British Association for Sexual Health and HIV, clinical standards for the sexual health management of people involved in sex work. The engagement that we've done with our stakeholder group has been included as a really good example of co-production within the Towards Zero paper for the Department of Health and Social Care around HIV testing. The British Psychological Society have developed some guidelines for developing chemsex intervention services. So again, we've fed through the experiences of men accepting rewards. In acknowledgement of the legal frameworks, we've submitted evidence in opposition to the proposed prostitution bill in Scotland, which is focusing on a Nordic model. And we've also presented the findings at a BPS-funded online webinar, and then internationally at the HIV and STI conference, which took place in Chicago a couple of years ago. Recently, we have been awarded some funding to explore opportunities around creating a digital health community for men accepting rewards. We are looking to establish a stakeholder PPI group, which we will then use as a basis to try and build and grow a digital platform that has capacity to evolve with need. And the feedback that we get from people. We see this having capacity for sharing lived experience. So this isn't about having information for men who are gay accepting rewards, men who are straight accepting rewards. It's based upon people's stories and lived experience, because in the absence of a universal language around this, this is what's going to connect people. We're looking to develop some resources, particularly around the response to those performance pressures, also with links to physical and digital health services, so STI screening, certs, access to PrEP, but also opportunities for networking with professionals so that they can work directly with this group. So that is everything. If anything today has interested you or you wanted to talk to me a bit more about it, I've got my email address there. It's kevin.turner6@nhs.net. I'm also on X as Kevin Investigates with an 8.